Good evening, everyone. My name is Sherry Soltani, and welcome to today's TV. Our focus today is about mental health crisis and the importance of mental illness awareness. Mental health is to determine how a person thinks, feels, acts, or behaves. According to Canadian Mental Health Association in BC, about 70% of British Columbians, somewhere around 800,000 people, are experiencing a mental health illness. So, in other words, in any given year, 1 in 5 Canadians experience mental illness by the time Canadians reach to 40 years of age. Therefore, it is extremely important to understand how to deal properly. But before we go into this discussion and to know how to prevent this from happening, we need to have the knowledge and we need to know what is the mental health crisis. Now, this is a question that we need expertise, an expertise or professional to address that. So we have invited Pega Behbahani, is a registered clinical counselor with the BCACC. She holds a master's degree in counseling psychology, and Elke Babiki, MED, RCC, she has actually consultant to corporation and clinical counselor in private practice in Vancouver and Toronto. So we are here to discuss about this matter and to learn and understand about mental illness and mental health crisis. Welcome, ladies, and thank you for coming to our show.
Hi, thank you for having us today.
Thank you. Thank you for having us.
Well, Pega, before we start, can you please briefly let us know about yourself?
Yeah, my name is Pega. I'm a registered clinical counselor with BCACC, British Columbia Association of Clinical Counselors. And I'm delighted to be here with you today.
Thank you. And Elke?
Hi, my name is Elke Babiki. I'm a registered clinical psychotherapist or counselor and have been in practice for 30 years. And I've worked in Canada, Europe, and have led workshops, worked with individuals and companies. And I've written 3 books, 2 in English and 1 in German.
Wow, thank you. Okay, can you please just describe the mental health trauma before I begin my questions?
Sure, Sherry. Trauma is a huge topic because so many people have experienced trauma on a small and a large scale. Small scale is everyday kind of trauma when, we hurt ourselves as children and we get feeling like we don't get loved the way we want to. That's the smaller trauma. But the huge trauma is to actually become a victim, become feeling like a victim. And those kinds of traumas often lead to post-traumatic stress disorder because eventually the person feels like they have lost trust in others. They keep thinking that the shoe is going to drop the next time, and they get into a negative attitude about predicting that something negative is going to happen.
Mm-hmm.
And that actually leads to depression. So then we have the term depression, which is, more long-term kind of thing. And today we talk about how to fix that.
Mm-hmm. Thank you. Pega, can you describe the typical symptoms of depression and how they may manifest in different individuals?
Yeah, sure. Depression can manifest differently in different individuals. However, there are some common symptoms and typical symptoms that I want to explain here. One symptom that I have been seeing in all of my clients is basically their persistent feeling of emptiness, hopelessness, and sadness. Basically, this feeling persists for an extended period of time and at least for 2 weeks or maybe sometimes longer. And the other symptom is they lose their interest and the pleasure in activities that they once enjoyed. And they feel demotivated and discouraged. And also, they have difficulty to feel pleasure and joy. The other symptoms is change in their appetite and their weight. Some individuals, the depressed individual, they reported that they have craving. They develop craving for some certain foods, or they lost appetite, and correspondingly they lose weight or they gain weight. And the other symptom is a sleep disturbance. That basically the sleep pattern will be compromised, and they develop either insomnia, that they have difficulty to fall asleep or to maintain their sleep during the night, or they may develop hypersomnia, that basically daytime sleepiness and also oversleep. The other symptom is fatigue or lack of energy. Depressed individual may actually feel exhausted, and they feel lack of energy, and even simple activity of everyday life can be really difficult for them to get them done. And the other is
Sorry that I interrupt you here because it brought me to a question that
yeah.
so someone that lack of energy or the fatigue, it could be a
Yeah.
sign of a depression.
If it comes with other actually some of the symptoms, not just basically by itself, it doesn't necessarily is because of depression. Because when somebody is, for example, I will explain later maybe about situational sadness. It's not necessarily clinical depression, but people who are struggling with some basically situational sadness may experience the same basically lack of energy, kind of lethargic, feelings, and yeah, it's not necessarily symptom of they have depression. Yeah.
Okay, and you were continuing, or
Yeah, the other symptom, there are other, more symptoms. That one of them is basically our cognitive ability will be compromised when we are struggling with depression, in a sense that they feel like scattered. They have a scattered mind. They can't. They have difficulty to concentrate and make decisions or remember details, and that I see in majority of my clients that they struggle with depression. Also, they feel worthless, and they get involved in self-blame, self-criticizing behaviors, and they excessively criticize themselves for perceived shortcoming or failures. And the other is physical symptoms. Some of my clients, they reported that they have physical symptoms like basically bodily pain or headache or digestive issues, and without any clear basically medical explanation. Also, social withdrawal or isolation. They lost the interest to be socially engaged with others, and they want to be disconnected and isolated from family and friends and basically social activities. It's important to note that not everyone will experience all of these symptoms. Individuals are different in terms of severity and duration of symptom. And also, it's very important that if individual experience some of these symptoms, they reach out to a mental health practitioner to get an accurate diagnosis and also a treatment plan to address this issue.
Thank you, Pekka. What is the various treatment options available for depression, and how do you determine the most suitable approach for a patient?
Many treatment options are available for depression. However, they found over the years that the most effective treatments for depression actually had to do with changing the thinking that is underlying the depression. So, the most effective type of therapy in depression is called cognitive therapy, which means essentially reorganizing one's thought processes and getting some kind of control over the thought processes. So, what are some of these thought processes that I'm talking about? The depressive person has an all or nothing kind of state of mind. The thinking is about, for example, if I'm not performing fully, I'm short of perfect and therefore I'm a failure. So it's kind of a black and white thinking and a all or nothing thinking. They also tend to overgeneralize a single event, leading to further events that actually end up to be a pattern of defeat. So, for example, I treated a young man who was trying to go out with a young woman, and she declined. After that, he decided he would never have a date again. So his thinking had that negative overgeneralization going. And that leads to a mental filter, and the mental filter becomes negative. So they are focusing on negative detail and see reality from that negative perspective through that negative filter. That means they tend to validate the negative and disqualify the positive. So the positive things that are happening, for some reason, they don't count. But the negative things they focus on. They also get into something called negative fortune telling, predicting that this is going to be bad. So it could be anything. It could be just driving down the street and there's a little roadblock, and they're thinking this roadblock is going to continue all the way to where I'm going.
Like
So
assumptions before happening.
that's right. Always sort of imagining the worst possible outcome. And that's like a catastrophic expectation thing. So always thinking, what's the worst possible outcome? And then actually thinking that that negative outcome will occur, underestimating the ability to handle it and overestimating that it actually is going to happen. So that kind of emotion actually comes from thinking, because the thinking underlies the brain activity that creates the chemistry for the emotions. And essentially, that therapy helps people process their emotions differently because it helps them examine the underlying beliefs and helps them reframe the underlying beliefs and develop better coping strategies, better behaviors, better patterns in their life, also to help them to trust again and see things in a light that enables them to see themselves less as a victim. Because when you have this negative point of view, it prolongs that feeling of victimization.
It's
And
like that's how their mind has been set, right?
yes, and how the mind has been reinforcing itself. Because once you believe in this negative pattern, you keep essentially knitting an armor, thinking that this is my life. And then you live that life, and that's what it becomes. So, therapy is about unraveling that armor and taking it off and finding better behaviors in the here and now to get control of one's life and to get away from feeling like a victim. So that is cognitive behavioral therapy. But there are other methods. For example, if you're traumatized, one of the really important methods that has been used for veterans, for example, is EMDR. That's a trauma reduction method because people, who are really entrenched in a trauma tend to be in a fight and flight reaction all the time. And the EMDR seems to break that pattern. So that it's another potential method that sometimes can be useful. Doctors tend to prescribe antidepressants a lot of times. That can be very useful. The most useful thing actually is to have an antidepressant if you can't function. Like if you can't sleep, if you feel totally unmotivated, if you continue to cry so you can't go to work, then an antidepressant probably really is helpful for a period of time to get you onto a more even keel.
So
So
the anti-depression is the key for people who cannot control their emotion, I guess.
yes, it's one way of helping get a handle on depression, to get out of the symptoms of helplessness and feeling, sleeplessness and not motivated and worthlessness, to help them cope. And the best thing actually is to have psychotherapy so you don't relapse. Because if you cannot actually reframe these thoughts, you keep believing these thoughts as reality. And these thoughts are not reality because we are more than our mind. We are not our thoughts. But most people believe their thoughts. And because of these thoughts, their emotions rule them. And a person who gets control is not ruled by their emotions. They choose their responses. They have control over choosing a response despite their emotions. So all these things are part of therapy.
Thank you, Alka. And Pega, what are
Yes.
the key difference between situational sadness and clinical depression?
Okay. So, yeah, it's a very good question actually, because sometimes people mix these two. Like situational sadness and depression, they are two distinct experiences. However, they actually have some basically similarities in terms of their symptoms, but they are two distinct experiences. Um, and from different, basically, I look at different aspects of that. Like in terms of cause, for example, situational sadness always triggered by a cause, by an event or circumstance. For example, a person can basically it can manifest by a breakup or a job loss or a grief for a beloved one. Uh, However, depression, on the other hand, is just persistent and ongoing feeling of hopelessness, sadness, worthlessness that it is not necessarily needed a cause, an apparent cause to start. Like this is one thing that makes them different, and the other is about duration. Like situational sadness is temporary and typically resolve itself as the individual adapts to the situation and obtains support. And but however, clinical depression, it's not like that. It actually can last at least for 2 weeks, or even sometimes when they don't address it, or they don't reach out to get support by practitioners and like therapists, it may actually last even for weeks, months, or years. And the other difference is in terms of severity. Situational sadness tend to be milder and less severe in terms of the impact on a person's daily activities and the overall sense of well-being. In a sense that a person who is experiencing situational sadness is able to engage in regular activities and maintain their overall well-being. However, a person who is experiencing clinical depression, basically, this depression can significantly influence their um, majority of aspects of their life. They lose their motivation even to do their work. They go to work, they get engaged with their family, it impacts their relationship, their self-care routine, and overall quality of life. The other basically factor that makes them different is about frequency of symptom. Emotional, basically situational sadness is usually tied to a particular trigger and basically is a normal emotional response to a challenging situation. So, and after a person basically when adapt to the situation and cope with the situation, it will fade away, and it's lasts usually a few days or weeks, not more than that. But clinical depression is basically persistent and recurring symptoms, and they are at least they last more than 2 weeks or months or years, as I mentioned. And about treatment approach for a situational sadness, we don't necessarily need any formal treatment. Just time and also support is very important. Or maybe also an individual basically learn or develop some healthy coping mechanism. It can be
Pega, I'm sorry that I interrupt you right now, but I have a question in this regard. How a person can find out that they have a depression? Like, I mean, that person living a normal life and they think that they're actually, coping with the sadness or that the clinical depression that they had, but they don't know that they are not aware that they have a depression.
Okay. Actually, it's a good question. Like, I actually explained through an example. I had a client that she came to me and she told me that I think I'm actually developing depression. I have depression. And depression actually is very kind of overused term in our society, unfortunately. As soon as you feel sad, you say, "Oh, I'm depressed," and I have to go to my basically
Counselor, yeah.
family doctor, yeah, no, family doctor, and ask for medication. It's like that. But it's important for me as a clinical counselor. I always see people in their context, and I ask them that recently. Tell me about like when was the onset of these symptoms? That you think. First of all, I ask them about their symptoms. What makes you think that you have depression? And so when they give me symptom, I always consider those criteria that I shared today. And after, if I see that they have some of them, I ask for, okay, is there any trigger? Like, when did those symptoms started, and around that time, tell me about your life, what happened. So, and usually, like about this client, she told me that I had a breakup, and also I lost my job. These are two big, actually, triggers. And so in this situation, and I asked her, okay, tell me about your everyday life. And I saw that regardless of these incidents, she's still trying to do her everyday daily life task and be still engaged in basically activities. So it actually shows that it's not really, because it's a spectrum basically. Yeah, it's not full blown, like depression, like that we can actually label it like that. And I gave her some basically definition, psychoeducation around the definition of depression and also situational sadness. And I gave her some tools how to relate to her emotions and other tools. And basically, a week after, she came back and she told me that I feel so much better. But in depression, it's not like that, it's persistent and it significantly impact your everyday life. You don't feel even any energy to wake up sometimes. Do you want to just cover, close your
The
curtain and
blanket
sleep?
on you and don't see the world.
Yeah.
Yeah.
So that's, I don't know, it's like,
Well,
yeah, you
thank you
got it.
so much, Pega. Now, Elike, how does a history of a trauma impact the development and treatment of depression?
Yes, trauma can bring on depression. It can be an acute depression brought on by a particular kind of trauma. So, for example, divorce can bring on depression, or having some kind of, physical trauma can bring on depression. What happens is the PTSD symptoms, the post-traumatic stress disorder symptoms, sometimes can become debilitating. So, for example, in my father, who was a concentration camp survivor of 5 of the worst concentration camps, what happened was he was transported from one camp to another in these horrible trains. And there was lots of death, and it was a constant not knowing where he was going. And he was unable to get on trains after he was free.
Where is
So
this? Is this in Germany?
yes, he actually stayed in Germany. And to his credit, he overcame many, many, many of these hindrances of whatever he now was dealt with. He had nothing and he had to build his life as a 20-year-old. But one of the things he couldn't do was get into trains. And that, of course, limited him actually from getting away from Germany. So, people sometimes become claustrophobic or agoraphobic. They have no capacity, for example, to go over a bridge. So they develop phobias. And phobias like that generally have some kind of sudden onset with some trauma. And, those are the kinds of things you need a really specialized approach. But trauma can really create the most disturbing images that keep repeating, and a person cannot get a handle on it. The most successful people in getting a handle on it are people in general having a lot of emotional resilience. What is emotional resilience? It's an attitude to just get on with it and know, I'm going to take it from here, and I've got control over what I'm doing now. And that is exactly the attitude my dad had. And that was the attitude that got him very far. But then if you get a roadblock, like, for example, a post-traumatic stress reaction or phobia, of course, there are limitations. But nevertheless, you can still create a life and really overcome many, many hindrances with emotional resilience. So, emotional resilience really has to do with putting yourself into the driver's seat, knowing that, yes, you have lost a lot of things, and emotionally resilient people do grieve, but they process things in such a way that they can actually move on. And they move on in an empowered way. So if you're feeling constantly victimized and that I can't handle this, then immediately there is a huge hindrance in creating a life. But if you have emotional resilience, that helps a lot with dealing with depression, dealing even with phobias, because you can still have a life even though you have a phobia. The thing with phobia is actually if somebody has, for example, claustrophobia or agoraphobia and doesn't get out of the house, it exacerbates the symptoms. And then the person actually needs to challenge themselves to get out of the house. Otherwise, it becomes a continuous rabbit hole where the person sinks deeper and deeper into, you know, into reinforcing their anxiety and their depression.
Well, thank you. That was very educational. Pega, how do you assess the risk of self-harm or suicide in a patient with depression? Because I know, especially in BC, there's a lot of suicide going on. And so, what is your thoughts about that?
Yeah. Um, Basically, assessment is a clinical task, because sometimes people they find some forms in the internet, and they think that, yeah, they go through that, and that they think that is enough, and they are not suicidal, or they loved one. But assessment is something that needs to be done by a clinical, like counselor or mental health practitioner. However, I can just give you a general, basically, factors that we consider when we want to assess a patient. So one thing that we kind of look out for is when they talk, they express themselves. Like basically, they send some verbal cues. For example, a client come and say that, what's the point? I'm like a burden to my family. I don't want to be alive. They are better off, without me, or this kind of like kind of language. It actually can be a warning sign that they are
Like
maybe
negatively mindset.
yeah, but yeah, kind of inclined towards like removing themselves. You know, what's the point of me being alive, or I'm a burden? This kind of thing. The other thing is their behavioral cues. For example, you see someone or the family members, they tell us that, he's kind of he loved like collecting. Let's say he was loved collecting things, and he's giving away everything. All of his precious like belongings, or they others suddenly they withdraw from basically social activities, or also they researching for suicide methods. So usually family also can sometimes I involve family, to ask some questions about that specific like person. Like the other factor that we consider is prior history. We ask clients if they have any history of self-harm or suicide attempts, and especially the recent ones. We want to understand the severity, and also this or frequency of that, and also the history in their family. also is something that we consider. The other is the psychiatric symptoms. Like if the clients, they have severe, persistent, like depressive, for example, symptoms, or they, like for example, they are feeling worthless, helpless, and agitation, irritability, all of these can be also a warning sign. Or also the other thing is presence of psychotic symptoms, like common hallucinations or delusions. Also, we assess that. The other is protective factor is very important. Usually, like protective factor is basically buffer an individual against suicide, risk of suicide. Like protective factors is like, for example, I ask clients if about their social life, about their social um, network, if they have friends that they can vent out, they can reach out, and also about a sense of responsibility. If they have, for example, a pet or a child that they feel responsible for that, or they have some sort of connection with someone that connection is very comforting and very promising to them. Like say for even with their counselor, that rapport, it makes a huge difference. It can be a protective factor. So these are the questions that I ask because sometimes people they have nobody basically that they can, if they have those suicide ideation and thoughts, to reach out and to share and to feel safe. The other factor that we assess is basically coexisting substance use disorder. It can improve risk of suicide in clients, and or even substance use history is something that we assess. Also, the other factor is access, our clients' access to means. So individual, if they have access to a lethal means, such as firearms or medications, or other potentially dangerous items. And this is also something that you need to talk to the family members that they are living with them. If there is, for example, I don't know, knives or rope, or some people they may have gun at home. The family members should hide them somewhere or remove them from home, from their access. And the other is their a factor that we assess is their current circumstances. Sometimes clients they are struggling at the present moment with some, for example, ongoing relational difficulties or financial problems, or for example, they are grieving for someone. These factors, this can trigger basically risk of suicide in people who are already have severe depressive symptoms. And this is very important that any mention or indication of self-harm or suicide thoughts, your ideation should be taken seriously. And if you know someone, like family members or people like in your social network that they are showing some of the symptoms, you really take it serious
It
and
should get
reach
addressed.
crisis line or some, really get support of professionals or crisis line. And yeah, it's very
Okay.
important.
Good to know. Thank you. Um, Elka, do you see depression, a mental health depression, in women or men more?
Well, depression actually is much more common in women. Depression and anxiety tends to be more of a woman's related, is a higher frequency in women. Men have more substance use and antisocial behaviors. So essentially, it manifests differently in men and women.
Sorry, is that
Some
because women have they show their emotion and they're more emotional? Is that why? Maybe.
right. Well, partially, there is some genetic difference. Like it could be menstrual cycle, brings on more depressive symptoms, but mostly it probably has to do with gender, um, essentially cultural differences in masculinity and femininity. And what people have learned is masculine and feminine. So men's anxiety usually is manifest very differently than women's. Women's is much more on the surface and it's very easily accessible and therefore also probably more easily treatable. You find a lot of women in psychotherapy because they like to share and like to admit that something is wrong. Whereas men, it is much more unusual for them to be in psychotherapy. They have the propensity to want to do it on their own. And they also want to do things more probably physically. So they may say, oh, I'll go for a run. Or they may also use drugs or tranquilizers to deal with their nerves if they have any problems. They say,
So,
oh,
sorry, the treatment for men and women is a different treatments or because of the, gender?
the treatments aren't different. The different medication, for example, are very different for different people. They affect people very differently. You have to be patient with medication because medication, antidepressants, is called serotonin uptake inhibitor, reuptake SSRIs. They act very differently on different people. So some people get side effects, and these side effects may actually go away after a few weeks. So you have to be patient with it. And it depends on not if it's a man or a woman, it depends on how a person reacts to the particular antidepressant. So there are different ones like Zoloft, Prozac, um, Lexapro. You have to be persistent to keep trying different ones. And like I said, women tend to seek help more readily. Men want to deal with it themselves. And also, it tends to be more suppressed. So it's more difficult to access because the man comes and says, me anxious? I'm not anxious. What are you talking about? I'm really calm. But in the meantime, he may have, physical symptoms of ulcers or other kind of symptoms, but he won't realize that actually is anxiety or depression based.
Good to know. Now, Pega, can you discuss the relationship between depression and other mental health disorders such as anxiety and or bipolar disorder?
Yeah, sure. Basically, depression often coexists with anxiety and or bipolar disorder. Like I most of the time I see clients when they come and they talk about depressive symptoms, they also talk about anxiety. Like the symptoms, like they have some basically common symptoms. Um, so the relationship is basically they, as I mentioned, they are coexist. Anxiety coexists with depression most of the time, and for example, some share symptoms are basically persistent feeling of sadness and fatigue, irritability, a sleep disturbance, and difficulty with concentration, basically cognitive ability compromise. And also, usually when, like it's basically it's very common for individual to experience both, at the same time simultaneously. So that's basically lead us most of the time with diagnosis of comorbid anxiety and depression. And also with bipolar, we have basically bipolar involves episodes of depression alternating with periods of mania or hypomania or manic episodes, basically. So
That's the meaning
during
of bipolar, or?
yeah. So bipolar, yeah, bipolar. Basically, it comes with depressive episodes and also some manic, basically episode periods of mania or hypomania. Basically, is overactive or high energy behavior that have a huge impact on everyday life of a person. Yeah. So during depressive episode, individual with bipolar disorder basically experience symptoms similar to major depression. However, bipolar depression is different from unipolar depression. So unipolar depression basically is depression without that mania, your manic episodes. Okay, so it seems similar. Basically, unipolar is similar to depression, but bipolar is in category of mood swing. Because that depression that we experience in bipolar is different than depression, like major depressive disorder. It comes with basically
Mood
episodes of
swings and
yeah, yeah. Depressive episodes and manic episodes is like that. Yeah. So it's very important in terms of treatment because we need to understand that basically the comorbidity of these disorders, because it impacts our treatment, especially if they want to prescribe. They go to psychiatrists and they need medication. So because sometimes we prescribe, like, let's say, medication for depression, but those medication can basically impact that manic episode. So that can actually improve the severity of those manic episodes, or in people that they are struggling with bipolar, disorder.
well, ladies, thank you so much. I think this is a wide range of the discussion that we need to carry on for next week, if you agree. But if anything that you guys want to add or mention here, that would be great. And then we can continue our discussion next week. If you have any questions or comments, please email us at skyrisemediasociety@gmail.com. Thank you for watching and see you next time.